So, the purpose of today's lecture is to look at acute orthopedic radiographs. So, what I'm trying to achieve over here is not to try and teach you how to diagnose degenerative changes and various endocrine disorders which can affect the bone, but straightforward fractures that you will tend to see in your day-to-day life, and also to sort of develop an approach for yourself on how to approach any radiograph that you may encounter in your career. Okay, so there are three sections to this one. We have the basics, which I'll just go through some basic principles on how you would do it and obviously give you some tips there. Then the various important radiographic views. Now, this is probably will be slightly more of a run-through purposes, just to show that not everything will have two orthogonal views. And by that, I mean two views that are at 90 degrees to each other, and obviously the value of having that. And at the end, we have a quiz where there are about 20 radiographs that I've got, where your job is to pick out the abnormality of what's wrong or what's the fracture on that particular radiograph. Okay, so we'll start with first and foremost the basics. So like with any radiograph, the first and foremost thing, like say be it a chest x-ray, an abdominal x-ray, or you're reviewing an x-ray in this case for trauma, make sure that corresponds to the name, that is the patient that you have assessed already clinically. What is the age? Because sometimes if you see something at a younger age group, for example, say the pediatric population, and if you see a line going through the bone on either end, it may be not a fracture, and it might just be the epiphysis or the physeal plate that you are seeing in that patient. And of course, the side marker. So for example, if a patient comes with a fracture of his left arm, somebody does a radiograph of the right arm and it says right as the side marker, and you go back to the patient saying, oh, everything is fine, don't worry about it, then obviously that's not good for the patient over there. And of course, what are the radiograph like? Now, is it the correct side? So like I said earlier, so is it if it's the right sided problem, have they x-rayed the right side? If it's a problem of the forearm, but have they instead x-rayed the arm, for example? And any adequate views, or rather, have they taken the adequate views for you to make a diagnosis? And if not, do you need any further views to reach a diagnosis or for that particular patient? So, as with anything, you develop a systematic approach to approaching a radiograph, and the most important thing from your point of view, especially when you're learning, is stick to it religiously, no matter what you're doing. Whether it is a chest x-ray, abdominal, or a plain film of a musculoskeletal radiograph, stick to the same steps that you would do day in and day out. Okay, now, when you come to interpreting a trauma radiograph, first and foremost is obviously the site, which is important, but you can look for some clues as to where exactly the injury is likely to be. So look for soft tissue injury, like you can see soft tissue swelling, and I will show some examples of that. There may be already an attempt at fracture healing, which obviously the patient has been, say for example, there's a fracture of the metatarsal bone, the patient has been mobilizing consistently, but then he comes in eventually because it's painful, as they all do. And then when you do the radiograph, you will actually find that there is some callus formation or healing around the fracture site. Now, some of the things that you will have to be aware of is what is the alignment of the fracture? That is, what is the angulation of the fracture or the fracture fragment? Are they in straight line, or have they moved apart, or are they rotated? Is the displacement quite significant? Is it just a simple break, or is it in quite a lot of bits, so what you call as comminution, or is it an open fracture, which should be fairly obvious from your clinical evaluation. Now, one of the rules that we teach people is, or radiology trainees, is that, for example, try and interpreting the radiograph, and if you have to discuss the radiograph with a clinician, put it in such a way that you would be in a position that by the end of your description, the other person should have had a mental picture of what you are trying to tell them. Even without actually looking at the image, they should be able to say, yes, I know exactly what you're telling me. I can exactly picture how this fracture is for this patient. And then accordingly, they will initiate treatment for that person. Okay. Now, I think some of the most important features of the fracture over here are is it could be the most important thing is alignment. And obviously, open fracture is important because that has clinical implications. Patients may have to go for surgery fairly soon because it's an open wound. There's high risk of infection in case of open fractures. Okay, so when you are doing radiographs, particularly for trauma, we have what is called as a rule of twos. So you need to do two views. So two views means one view is generally what we do is an AP view, which is a standard view, and you need another supporting view, which could be 90 degrees to it. In this case, it could be a lateral, but not always, and sometimes it could be an oblique. You will see examples of that. Now, if you've got a fracture, say, of the tibia, both two joints, both above and below the fracture, should be imaged. So, for example, so in the case of a tibial fracture, your radiograph should include both the knee joint and the ankle joint. And that is very important because the fracture line may extend to the either ends of the fracture or to the either ends involving the joint surfaces. And that's important for you to identify because intra-articular extension, whilst some of these patients may be treated with just a plaster cast or they may have open surgery by the orthopedic surgeons, when a fracture line tends to involve the joint surface, there is a higher risk for these people developing osteoarthritis in the future, simply because of the fact that the joints are, because the joint has lost its congruity and is no longer functioning as a normal joint. And also, another time you've got to do is one before and after reduction. And this is important because when you look at a radiograph during a reduction, just before, say, when a joint is dislocated, then you may actually miss subtle fractures that may be apparent because there, but you couldn't see it because of bony overlap. But after the joint has been, or the dislocation has been reduced, then when you re-X-ray the person, two benefits there. One, to make sure you've done the job of doing a satisfactory reduction. And secondly, is are there any fractures which will need the attention of the orthopedic surgeon at that eventually? Okay, so remember, always get two views. Either you get an AP, which is pretty much standard, and then you get a lateral or an oblique, depending upon circumstances. You make sure you have two joints, both above and below the fracture should be imaged, and you should have both before and after reduction of a dislocation is very important. So just going through some of the rules over here. So now you can see in this particular finger over here, that is the normal alignment with, the joint space is pretty evenly spaced throughout over here. Now here, you could be forgiven saying, okay, yes, that is widely, there may be a little bit of subluxation, maybe there's just a ligamentous disruption over here. But when you take the other view, which is a lateral view over here, you can see it's not just simple ligamentous disruption and mild subluxation. This is actually dislocation of the proximal interphalangeal joint. So this patient will need to have that reduced and then splintered accordingly to manage it. Now, take this one here, for example. So this is a spinal radiograph. Now, yes, the fairly obvious abnormality here is you have a fracture involving the L2 lumbar vertebral body. Yes, there is some posterior movement, which could imply that the spinal cord is probably compromised. But when you get an AP view for the same person, you actually see the degree of seriousness of the injury over here, which has moved things apart over here, which obviously this would require a spinal surgeon to attend to immediately to prevent any further damage to the spinal cord or the nerves coming off the spinal cord in this case. Now, you get different types of fracture patterns, okay? Not all of them will be the same which you will encounter in your career, and I wouldn't be surprised if you did a night shift in A&E, you probably see at least 70% of these kind of fractures of this kind of fracture patterns. So the most simplest one is what is a simple transverse, literally a break through the cortex or a break through the bone over there. Then you can have what is called as a spiral fracture, where it's spiraling round the bone shaft of the bone over here. It could be oblique, which is basically a simple fracture, but at a more at an angle. You can have a longitudinal fracture like this, which is extending to involve the articular surface of the distal femur, comminuted where there are multiple bits. You have 1, 2, 3, 4 bits as in this case. Impacted as in this neck of femur where the two ends actually just go into each other. It's like sort of telescoping of the fracture fragments into each other. And a depressed fracture is where it's just this, say for example in this particular region of the condyle here, it's just pushed up against each other. It's almost like compressed over there, and that's a depressed fracture. So now, does recognizing a fracture pattern make it all the more difficult, or is it more important? Well, it does. So for example, if you have somebody with a simple fracture, the surgeon may opt to see if they can conservatively manage or put an IM nail over here. Whereas for an oblique fracture, an IM nail may not be. He may choose to put screws going across it. Comminuted fracture, obviously slightly more difficult to treat. They may just stick an IM nail and hope callus formation will unite all the fractures over here. So whilst your job, especially as final year medical students, your purpose is obviously to pass exams there, and eventually as foundation doctors would not be to decide what the treatment options are for the patient, but it would help you to describe things. And perhaps, if you're asked to judge the seriousness of a case, you could do that. So one of the things that I do when I view a radiograph is, first thing foremost is know your anatomy well. Okay, so you need to know what bone you're talking about, what are the various parts of the bone. So for example, in a femur, you have a femoral head, you have a femoral neck, you have the greater trochanter, the lesser trochanter. So you need to know your anatomy to describe it. Okay, now one of the things which I still do as a consultant is that I trace the margins of the bone. So just to go back, and when I say trace the margins, you can see here, so this is the margin of the bone. So I trace it to see if there is any break, any sudden angulation, because one thing we do not see in the human bones is there is no such thing as sudden angulation. Everything is a smooth transition. Okay, and that is very important for us to have. Okay, so there should be no sharp transition. Remember, fractures and dislocations can coexist. So fracture can become more apparent after the reduction of a dislocation, hence why you would take a view before and after a dislocation has been reduced. Look for clues: soft tissue swelling, air in the wrong place. There's an example of a facial fracture which I will show you later. Callus formation, that is the process of healing around a fracture fragment. Importantly, compare with any old imaging the patient may have. It is very easy sometimes when we see lines, we immediately get excited, black lines on a radiograph, and say that's a fracture. But that may be what the patient has had before. It might be a non-healing fracture, in which case an orthopedic surgeon isn't going to get excited about it because it's not an acute problem at that point in time. And more importantly, there are mimics which might resemble a fracture but realistically are not. For example, patients may have unossified centers, may have accessory bones, and also the medullary canal which transfers the artery there, which can mimic a fracture. I will show an example of that as well. So if we come to the first principle second one, which is trace the margins of a bone. Now, this is a pelvic X-ray. I hope it's projecting well at your end. Now, the history provided for this patient was history of fall, pain in the right hip, unable to move the right hip. So the first thing, especially in an elderly patient, we are concerned about is this a neck of femur fracture? Okay, so in the case of a neck of femur fracture, so we assess the femoral neck over here, and you can see when you trace the margins, it's actually quite clear. And the Shenton line, which goes along the superior part of the obturator foramen, and it goes across, and you can see it's a smooth curve coming onto the medial aspect of the femur over there. So that's intact. So you then start looking for what is causing the pain for this patient. Is it truly a fracture? Maybe it's a flare-up of arthritis. One. Now, have a look first on the left-hand side. So if I trace the margin of the bone over here, that's pretty smooth and there's no sharp corners or turns or anything. But when you come over here, as you go up, you see there's a little projection of the bone over here, and then it continues. So this is a magnified view of the same one. I've kind of blown it up, and then when you focus a little bit hard, or what I say, squint your eyes even harder, is you're going to see this black line over here. So that indicates this is a fracture of the superior pubic rami on the right side, which is what is accounting for the patient's pain. Now, I guarantee you a vast majority of the fractures you see are not going to be subtle like this or slightly difficult. Most of them will be fairly obvious to you, and you'll be able to look at it and say, right, that's a fracture of that particular bone. But sometimes you will encounter these very subtle fractures over here, which will need. Now, how would the surgeon treat this? Probably they won't treat this. They will just say bed rest for the patient and analgesia, and that's what it is. But the important thing is recognizing it so you can give appropriate advice to the patient. Okay, now another example of sharp margins and also an associated signs. Now, elbow is one of those regions of the body where people tend to have times they have a fall, they injure the elbow, but unfortunately there is nothing to really identify when you look at a radiograph. So if you look at this here, this is the distal part of the humerus, this is the radius, and this is the ulna. So history of fall, painful elbow, not able to. So this is a radiograph that's been undertaken. Now, the first thing you will notice is here, this picture is a touch blurry, but it looks there's a little bit of blackness there and more of the whitish gray beyond it. But over here, you see there is some sort of protrusion, like the black thing that you saw here is pushed out. Similarly, it looks more prominent on this side as well. This is a joint effusion, and that automatically has to signal to you in the event of a trauma that there is something wrong. There is a fracture somewhere. It may not be apparent to you, but there is a possible fracture. Now, if you then look at the radius over here, that's a relatively smooth transition, and it goes, and similarly along here, it's a smooth transition. Yes, there is an overlap of bone, but you can appreciate it over here. Whereas if you come to this radiograph, which has got the effusion over here, you can trace the bone, you're going over there, and then suddenly it's almost like it's at 90 degrees over here. Okay, so if I was just to annotate this picture here, so over here you can see it's a smooth curve, whereas over here it comes up to this point and it just takes sort of a 90 degrees. So you got this sharp angle, and in fact you can see there is a small fragment of bone protruding out over here. So this is a case of a patient who's got a radial head fracture with an associated effusion within the joint over here, and that's the reaction to the one. So look for joint effusion, and that will point you to the fact that there is most likely to be an injury for you to identify. Okay, right. So over here again, this is a patient who had twisted their ankle. So they came in with pain and swelling along the lateral malleolus over here, and there you can see there's a nice soft tissue swelling over here. But as you look on the contralateral side, which is on the medial aspect, you can see there's a very little soft tissue thickening between the bone and the actual skin, whereas here it's quite marked. So that itself is an indication to you that there may be a soft tissue injury. Now, one thing you will notice whenever you do A&E, a lot of people will come in with ankle injury, twisted ankles, fall, unable to weight bear, etc. And all of that invariably is just ligamentous injury with soft tissue swelling, but there will be no bony injury for that. And then coming on to the this radiograph here, you can see, now look at this metatarsal bone. Now that's nice and smooth, almost smooth, again fairly nice and smooth. But when you come here, you got sort of a little protrusion on either side. It's like a swelling on either side of the bone. This is what is called as callus formation. So this is a patient who had a stress fracture. So perhaps through repetitive activity, they have sustained small microfractures over here, which over time, he gets a microfracture, it heals a little, he gets another microfracture, it heals. So eventually you get this sort of callus formation around the fracture site for these patients. So, but per se, when you look at the radiograph, there is absolutely no fracture associated with this thing. So some of the one of the most important takeaway point from this is always trace the margins of the bones that you suspect or want. I mean, obviously, when you come with a foot radiograph, you've got so many bones here. Yes, you are required to, it's in your best interest to look at each bone and quickly trace them and make sure that there is no sudden sharp angulations like we saw here with the radial head, because if that's the case, then that is the site of your fracture. Okay, now remember, I told you not every white line, the black line that you see on a radiograph corresponds to a fracture. Some of them could be normal physiological variants that the patient has. So, for example, now this here is a foot x-ray with a navicular bone, and you can see there's this extra piece of bone over here. Now this extra piece of bone is in what we call as an accessory or an ossicle or an accessory bone, and so this is not a fracture, this will just be a normal variant. Now the next question you probably would want to know is, how would I say that's a normal variant or this is a actual fracture? What we say is, look at the cortex of say in this case, this calcified structure over here. Now if it's a nice clear margin, so for example, if I were to give you a pen and you would be able to draw around the margins very clearly, then it would be very easy. Then you would know for sure that this is an ossicle. Now, if for example you can't draw around one margin because it's very irregular, can't define it, then you're probably dealing with a fracture. Okay, now this is another example. You can see it's a nice clear line. You would not be, you could be forgiven for saying, yes, this is a fracture of the fifth metatarsal bone, but in reality, this is nothing but an apophysis, which is basically an ossification center which hasn't fused yet with the metatarsal bone over here. And if you look at the edges, they are relatively well defined, they're a bit sclerotic, and you can actually clearly draw your lines around it. So this is not a fracture, this is just an apophysis or a secondary ossification center. And if you actually look at it, this is a pediatric child, this is a pediatric patient, because you can see the epiphysis, the physis over here. So this is a young person, as opposed to the foot radiograph of an older person where the bones have all the centers have fused for the person over here. So particularly more so in the pediatric population, you've got to be careful to make sure you don't call a physiological variant or a normal anatomy as pathological. Okay, now this is another radiograph. This is a femur bone. I had to mag it up so you can actually see it better. And you can see there's a little black line that's running through the cortex. Now, if this line was going through and through, you would be absolutely right in saying that this is a fracture. But what we are seeing here involves only one cortex, because you don't see any black lines crossing the other cortex, and this is what is called as a nutrient canal. So basically the nutrient artery which supplies the bone, the artery enters through this side, and then once it's in the medulla, it distributes into various branches to supply the rest of the bone. So this here is a nutrient canal and is a normal variant. Okay, so again, just going back to some important principles again, because when you see these radiographs, first and foremost, try and correlate the history that's provided. So for example, if someone says to you, oh, I've had a fall, my hip is hurting and it's the right side, focus on that area first. Then try and trace the margins of the bones that you are examining or you're reviewing on the radiograph. Okay, and if you see any sudden angulation or any small spikes which it shouldn't be there, then the chances are you are dealing with a fracture at that site. Okay, but again, like I said, beware of the variants that you come across, because these can change because they can mimic a so-called fracture, but in reality they are not. It's just normal physiology.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.